We're doing this as a split lecture tonight because I wanted to talk to you a little bit about fatty liver disease. And then we've recently started working with Dr. Catania's team at Southern New Hampshire to help us with some of the patients that need medical bariatric as well as surgical bariatric. So we thought we would talk about both and then introduce them to the community. So I'm going to be talking to you a little bit about fatty liver disease. So I am a GI doctor. You probably remember me from the colonoscopy talk. I appreciate you coming back after that. But GI docs also take care of the liver. And one of the things that we see a lot of in our community is fatty liver disease. And so I just want to talk to you a little bit about that. And the talk is going to be that I'm going to describe what fatty liver disease is. And then I'm going to kind of give you a sense of the burden in the world. And then I'm going to talk to you about what can happen. So if it progresses, what happens. And then we'll talk about some of the things that we can do to help it get better and help prevent the complications from it. With all my lectures, if you have a question anytime, just shout it out, raise your hand. I'm happy to be interrupted. And then I'll do my 15, 20 minutes, and then I'll turn it over to Dr. Catania, okay? All right, so fatty liver disease. So in medicine, we like to give lots of different names to the same thing. So some people have called it NASH or MASH or non-alcoholic fatty liver disease or MASLD, and it's all the same thing. So essentially, it's fat in the liver. And a lot of us get some fat in our liver. So actually, when we have a feast, our body first, fills up our blood sugar, and then we make glycogen. And glycogen is a quick store that lasts us less than 24 hours. And then anything after that is made into adipose, and adipose is made to help us have energy for when we have a long period of famine. And so one of the places that your body accumulates adipose tissue is in the liver. And if you think about it, pretty much every American after Thanksgiving dinner has some fatty liver disease. Not a big deal. And as you can see up there, it's completely reversible to get some fat in the liver, and then when you use that up metabolically and convert it from fat into blood glucose, the fat goes away. The challenge is that if you have more and more fat staying in the liver for a longer period of time, it starts to do some beta oxidation. It starts to cause some inflammation. And when you get inflammation in the liver, then you get what's called NASH, or non-alcoholic steatohepatitis, which means essentially there's inflammation in the liver and your liver tests have gone up a little bit. So, when you get your blood work for your PCP and they say, oh, your AST or your ALT has gone up, that means your liver tests have gone up. It means that there's inflammation. Now, there's a textbook of things that can cause your liver tests to go up, but one of the things is fatty liver disease. A lot of the terminology they have where they say non-alcoholic is because originally we were trying to separate it from someone who had alcoholic steatohepatitis. So if someone has alcohol use disorder, alcohol can be broken down into triglycerides, and triglycerides then can turn into fat. And so alcoholics can have fatty liver disease, and they can go down the same pathway. So once you get enough fat in the liver, then you start getting your liver tests going up. And the thing that we're always trying to avoid, though, is the progression to cirrhosis. So cirrhosis means a couple of things. One, it means scarring in the liver. So that chronic inflammation that we were talking about has started to do some damage to the architecture of the liver. It's causing fibrosis, which is scar tissue. It's that constant repair and trying to fix the chronic inflammation causes scar tissue. Eventually, though, what can happen is the liver can fail. So the liver can go into liver failure, and that's actually a decompensated cirrhosis. And decompensated cirrhosis is very dangerous and can be life-threatening. So what we're always trying to do is find people when they just have fatty liver or maybe some NASH, help them do the things that are reversible so that we can get the damage out of control and try to prevent it developing into cirrhosis. So how many people have it? So if you think about it, about a third of Americans have some level of fatty liver disease. And as we look at, today towards the 2050, it's increasing to almost half of Americans having some level of fatty liver disease. Doesn't mean that they have cirrhosis, but they at least have fatty liver or probably some of that steatosis causing inflammation in the liver. They're predicting that it's going to be more than 122 million people by 2050. And the big thing, though, just having fatty liver isn't the problem, but the problem is that over the next 30 years, we're going to have decompensated cirrhosis triple. There's compensated and decompensated cirrhosis. Decompensated cirrhosis means a constellation of things like ascites, which is a large abdomen full of fluid, which is dangerous, or bleeding varices or encephalopathy. They're the things that the liver is failing so badly that it's progressing towards a fatal illness. So one of the other big problems is that a cirrhotic liver can get liver cancer. That's called hepatoma. That's an amazingly dangerous cancer to have. And then they're saying that we're going to have our liver transplantations quadruple, in the next 25 years if we don't get this under control. This is just a map of the world, and the main thing I wanted to take away is that it affects a lot of the world, but America has it worse than anyone else. So this is very much something that's affecting our country, and the challenge is it's a tsunami. So when I started training, the big thing that we were working on was hepatitis C. So hepatitis C was a virus that you can get from blood products. And a lot of people in the 60s, if they had even dabbled in IV drug use, had gotten hep C, but they didn't know it because it doesn't have symptoms until it's progressed to cirrhosis. So we were rapidly trying to find ways to treat hepatitis C because it was causing so much cirrhosis that people were dying on the transplant list. Fatty liver disease has now completely surpassed hep C as a cause of end-stage liver disease. One of the good things is we've actually found amazing treatments for hep C, so that's part of it. But we actually have an incredible tsunami of fatty liver disease progressing to cirrhosis over the next 25 years if we don't do something to try to get it under control. The challenge is there's so many more people who need a liver transplant than livers available. Liver transplant centers usually use what's called a cadaveric liver, right? So someone unfortunately dies, they're an organ donor, they donate their organs, and we can use the liver. They've now moved to doing what's called a live donor. So a live donor, a family member or someone can give a part of their liver, and then they keep the rest of their liver, and the transplanted part goes into the person. The amazing thing is they actually both grow into full livers over almost a year, but we need so many more livers than we have, and people are dying on the transplant list every single day. All right, so what causes it? The things that cause NASH or MASH or MASLD or whatever you want to call it, fatty liver disease, are some of the same things that cause stroke and heart attack. So if you think about diabetes, if you think about high cholesterol, hypertension, dyslipidemia, so people that need to be on a statin have bad cholesterol levels. One of the things that we're finding is that dietary is a big cause of it. So not just fructose, but more importantly, high fructose corn syrup. And if you look at anything that you buy in the store that comes in a box, I can almost guarantee you that one of the major ingredients is high fructose corn syrup. It's dirt cheap. The Corn Lobby also supported getting it put into things. It's a sweetener, but the problem is it causes tremendous damage in the liver. Your liver actually kind of preferentially takes it, makes it into triglycerides, and stores it in your liver. The other challenge is that our lifestyle has changed, right? So if you think about back, millennia ago, we either raised something, hunted something, or grew something and ate it. Nothing came in a box back then. We also had periods of feast and famine. I guess one of the blessings of being in America is we haven't had a famine, but also one of the challenges is that we're getting the unintended consequences of not having any famine. And we all get, 3+ meals a day, and our lifestyle has changed, and we all have desk jobs now instead of working in the fields or, working heavy labor. That's had some consequences where our bodies are suddenly never in that unfed state. We're never fasting. And so our body is just constantly trying to store and store and store because we're not actually utilizing all of the energy that we're taking in. One of the things that, as I had mentioned, is that people who have some centralized obesity or any of those other kind of metabolic risk factors are at higher risk for having fatty liver disease as well. Genetics does play a role in it, so it does run in families. And for instance, Mexican Americans have a higher risk of fatty liver disease than other races do. The big thing I want to talk about, though, is insulin resistance. And going back to that high fructose corn syrup, our diet is probably shifted a lot towards carbs, right? So if you think about how we should probably be eating more of a Mediterranean type diet, so mostly vegetables and some lean protein, our diets have really shifted over to being much more carb-centric. And I would say probably garbage carbs, right? So it's not like good, healthy, complex carbs. It's things that are either ultra-processed or might not even really be food anymore. They're more like a science experiment, with a label of 30 different things on the box that you can't even pronounce. And a lot of that is causing our insulin to spike. Insulin is a very, very important hormone in our body. So your body needs insulin to move glucose out of the blood and into all of the different organs, except for contracting muscle, but I'll come back to that. But what happens is if your body is always in a state of having high blood glucose or always readily available glucose, what happens is the cells of your body become resistant to the insulin. So it takes more and more and more insulin to get the cells to take up that glucose. And that's why when your doctor is looking to see if you have diabetes, what do? They look for a fasting glucose. And if it's too high, it means that there's too much swimming around in your blood. And what it's actually a surrogate for is that you actually have insulin resistance. The good thing about insulin is it helps your body take up things. The bad thing is it's a tremendous growth factor. And one of the things it really prioritizes is making fat. If you have high insulin levels, you're going to have high adipose levels everywhere. So it increases your risk of heart attack and stroke and fatty liver disease. And it causes the centralized obesity. The other problem with insulin is super high levels of insulin is carcinogenic. It leads to different types of cancers. And we're seeing an incredible amount of cancers throughout the country in what I do. So if you remember, I do colonoscopies. Previously, we used to start doing colonoscopies for screening at age 50. We've started doing them now at age 45 because we were finding cancers in younger people. And now the sad thing is there was just a fact that came out that in patients between like 35 and 45, colon cancer is the #1 cause of cancer death. And the reason that's skyrocketing is because of all of these things, partly because there's a lot of poisons in the food we eat, but a lot of it is because of this.
Excuse me, Dr. Gilbert,
Yes.
Does age impact at all, increasing age? Does that?
Yeah.
As a risk for
Absolutely, and mostly though because of a couple things. So every decade after age 30, you lose 8 to 10% of your muscle mass unless you fight for it. And so there's something called sarcopenia, which is the loss of your muscle. So as people age, they're losing muscle. Muscle is what counters the adipose tissue. If you think about them as kind of being a yin and yang in the hormonal balance, you want the muscle to outweigh the fat because otherwise you're going to be in that phase where you're just creating more and more adipose tissue, getting more and more insulin resistant. So that happens. The other issue is that if you have more and more decades of the insulin resistance, that contributes to it as well. And going back to the insulin, almost 10% of our country currently has diabetes. So that means that they are in that very heightened state of insulin resistance. I'm not talking about type 1 diabetes, which is an autoimmune process where the pancreas is under attack and it can't make insulin. I'm talking about type 2 diabetes, where essentially your body is in a chronic state of insulin resistance. And so when you think about it, I get a lot of referrals for this, and usually it's primary care doc has run some of your annual labs, and when they're running their labs, they're like, oh, your liver tests have gone up. So what do? They get an ultrasound, right? And then usually the ultrasound says, hey, there's some echogenicity. Essentially means, the shadows of the ultrasound waves are saying that there's some density to your liver. And what they say is that it's usually from inflammation or fatty liver. And so a lot of times they're going to come to me and we're going to start doing some more testing. We're going to look and say, like, geez, what are your insulin levels? Are you in a insulin resistant state? What is your A1C? A1C looks at what your blood sugar is over 3 months or so. So it gives us a sense of if you're running chronically high and if your blood glucose is up, if you're about to get diabetes. And then we, again, look and see, do you have things like hypercholesterolemia? Are you dyslipidemic? Are your HDLs and LDLs all out of whack? And are you kind of going down that metabolic pathway? Once we have that, we need to do a little bit more imaging. So again, the ultrasound is a good screening test, but it doesn't really give us a lot of information about how bad things are. Now, historically, when I was starting my training, we would have the really awful conversation about the liver biopsy that I needed to do on you. And a liver biopsy is exactly what it sounds like. We put something about the size of a cocktail straw into your liver and pull out a core sample of tissue. And we're looking for two things with that. We're looking how fat is the liver, and then is there scar tissue? Because you'll remember, what we care about is scar tissue. Are we going into cirrhosis? And then do we have to worry about decompensation? So now we do something called a FibroScan. It's a type of elastography. So it's a vibratory test. And essentially, the waves of the ultrasound are vibrating the tissue. And they look at how it responds to that vibration. And denser things vibrate differently than things that are not dense. And what they're looking at is two things. Again, how fat is the liver, and is there inferential information that lets us say, oh, there's a chance that there's some scar tissue in there. It's a really great test to do, and it's a lot nicer to have a conversation about than the liver biopsy. Currently, we don't have a FibroScan here. They're like $50,000. We refer them out, and our colleagues are working on it. So currently, we do send folks to Dartmouth. We send folks to Cheshire, but our colleagues are working on getting one. They are expensive, but it's a very important piece of information because, if I get back that, hey, you've got some fatty liver and no scarring, we have some time to work on that. If I get back, wow, you're cirrhotic and I'm glad we caught this, then we have to have very different conversations. There's another test which is even better than the FibroScan called MR elastography. So it's a type of MRI. MRI can get us deeper information than a FibroScan. FibroScan only has so much penetration that it can get into tissue, especially into denser tissue. And FibroScan is really good at saying, hey, there's nothing wrong, and it's really good at saying, wow, it's really bad. It's less useful in that gray area in the middle, and MR elastography is a little bit better at that. But it's also, you're going in the MRI machine, which is not exactly as much fun as just having the FibroScan. And it's a much, much, much more expensive test. The last I checked, it's not just a regular MRI magnet. It's like an extra $1.3 million magnet, so less places have them as well. All right, so what do we do to help this? We have to address all the things that are leading to that metabolic dysfunction. And this falls under do as I say, not as I always do, because I've got a wife at home who's trying to get me to eat healthier and exercise more too. But when we're in my office, it's do as I say. So there's something called a Mediterranean diet. So you guys have heard of the blue zones, right? Those areas where people all live to 100 and they walk really far and they eat really healthy. We're all supposed to be doing that. We're supposed to be getting much more than our 10,000 steps. And most of us probably get less than 2,000. We're supposed to eat things that I've heard are called fruits and vegetables. Again, my wife and I are still working on this, but you're supposed to eat fruits and vegetables, and we're supposed to eat lean protein. and we're supposed to exercise. We're really, really supposed to exercise. And I will give a big push for this. Walking's important. I'm never going to say not to walk. But I would love to see people actually lift weights. Because going back to that sarcopenia conversation, if you can build up your muscle, you can start to shift that balance. Your muscles are going to help you take up glucose. And if you're exercising, they take it up readily. And what can happen is you can do things that will rapidly change that insulin resistance. I mentioned before that insulin is great at getting blood glucose out of the blood and into the cells. And all cells need that except for contracting muscles. So if a muscle is contracting, aka working, it has some ways of taking up blood glucose independent of insulin. And so what can happen is you can drop your blood glucose levels. And then what happens is the cells are able to do it with less insulin, so they become less insulin resistant. So we can actually reverse some of the challenges. And then what happens is if you actually shift enough, your body will start actually breaking down those other things I talked about, like glycogen and adipose cells, because you can take fat and make it back into triglycerides, and then you can take that and eventually convert it all the way down to blood glucose. So that's the whole process we're trying to talk about. Intermittent fasting. I really want folks to start thinking about that. And you have to understand, I've started doing it, and it takes time. You have to build up. It's like running a marathon. You have to do it slowly. And, you know, my team will tell you, I'm kind of like a Labrador retriever. I'm very food motivated. So like that first time that I skipped a meal, I was pretty sure I was going to die. You won't. You'll actually be okay. And if you can, you should actually try to slowly increase it. So there's one model of intermittent fasting which is called a 6-18 or an 18-6, depending. And essentially, you eat within a smaller window. And it doesn't even matter if you change the amount of calories. You can still eat a garbage can of bad food, but if you eat it in a tighter window and then have a longer period of fasting, your body will go through some of the changes that we're talking about, where it'll start saying, hey, where's the food? The blood glucose drops. Suddenly, you start breaking down glycogen. Suddenly, your body becomes more sensitive to the insulin. When you start going for longer fasts, so a 24-hour fast or longer, I mean, there's some people that do 48 and 72-hour fasts with just water. And again, if you're going to go that long, do it under medical supervision, do it properly, because there are other things that can happen. But if you're even getting into like a 24-hour fast, it's amazing some of the metabolic changes that happen in your body that will help you start breaking down adipose tissue. But also there's actually more like hormonal changes where you get growth factor. And so when you're lifting weights, your muscles get bigger and bigger faster. And so you can start shifting over some of the things that are actually taking us away from that metabolic dysregulation. Go back in your mind to my first slide. Remember where it was healthy liver, fatty liver, NASH, cirrhosis, and in between the first few it said reversible. So it doesn't take a lot to start tipping things the other way. They say that, I was always taught, try to get folks to lose 10% of their body weight. And if you do, what you'll see is that the fat in the liver is mobilized. So you're not in a state of fatty liver any longer. There's now some data that, you get 3%, you're actually making a difference. And it's that combination of like doing some walking, doing some intermittent fasting, doing some weightlifting. Going back to the blue zone people, one of the things that they do that's probably the smartest and easiest is they just go for a walk after every meal. Because if you go for a walk after every meal, you're contracting muscles. If you're contracting muscles, they're taking up the blood glucose that you've suddenly flooded your body with, with the meal. And it can actually make your blood sugar and your insulin resistance change dramatically. Always, 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 always lifestyle modification first. But there are some medications that can be used to help people. So metformin is a diabetes medicine, and it helps with some weight loss. It does help decrease the blood glucose. one of the important things though is it affects the way that your liver does some of that processing of blood glucose and adipose, and it can actually help decrease some of the fatty liver in and of itself. You have to kind of ramp up into it. One of the fun side effects of it is it gives really bad diarrhea your first few times, so you have to kind of ramp up your dose because that can be a little bit unfortunate. And then I'm sure you've all seen on all of your favorite TV shows the commercials for the GLPs, right? Anyone who's seen Hollywood and seen all the cachectic people on the red carpet, GLP meds, they're important. They're part of our arsenal. So what they do is they make your body essentially feel full. You think about how you feel after Thanksgiving, right? You're like, I can't eat another bite. And your body starts kind of going into that fasting. The GLPs help us start getting our body into that. They are really good at helping people lose weight. They are really good at helping with the metabolic things that we were discussing and trying to shift that. And they can really get some people to the point where, hey, they've lost enough weight where they can start exercising again, or they can get their knee repaired so that they can start exercising. So they absolutely are good things to have in our toolbox. One of the warnings that I will give you is something that I worry about, is that they said that there was a study where they were looking at postmenopausal women. And they said for the postmenopausal women, 40 to 45% of the weight that they lost was muscle and bone. And then the challenge is, if they go off the medicine, weight comes back like that, and it's all adipose tissue, and you don't have the bones to support the extra weight, and you don't have the muscle to help burn the calories, so you get into a really, really bad cycle that way. If we're all lucky enough to live into our 60s, 70s, and 80s and not die of cancer and not die of stroke and heart attack, one of the greatest risks to life is falling down. And sarcopenia and thin bones, especially again in postmenopausal women who are already at risk of osteoporosis, that could be a deadly combination. So I'm not trying to say don't use them, just any medicine, always in addition to lifestyle modification, and always use the medicines in a way that, again, helps you get back to lifestyle modification. I'm going to now hand it over to my colleague, Dr. Catania. He's going to talk a little bit about everything his team's done, medical and surgical bariatrics. We're very grateful to be able to work with them. They're the premier group in the state, and they're doing a lot of good for the community. Thank you.
Thank you very much. So, thank you, Dr. Gilbert. So I don't have a whole lot of slides because I wasn't sure what he was going to say, and I didn't want to say the same thing. So now I can talk about anything I want. But what that means is our talks are going to be very, very complimentary because I agree with every single thing he said. Specifically starting to talk about fatty liver, and then we'll move into kind of health and wellness in general. But if you looked at the slide that he put up that had 5 things that were associated with fatty liver disease, 4 of them we can deal with weight loss. One of them, genetics, you're going to get that no matter what you do, you've got it and you'll keep it. But 4 of the 5 factors that preclude people for fatty liver disease, or not preclude, but push people toward, sorry, brain fart, are modifiable based on weight management. And so I will also tell you that obesity in the United States is the #1 most common chronic disease, right? And obesity really is a disease. A lot of people in this room have gray hair like me, and so you were not raised to believe that obesity was a disease. Most of us were taught from early childhood that people with obesity are just lazy, they make bad food choices, they eat too much, they don't exercise. If they just ate less and exercised more, this would all go away. Right? I'm here to tell you that is absolutely 100% false. If you need to lose 5 pounds, you can do it by modifying your diet and exercising. If you need to lose 50 pounds, almost nobody, less than 1 in 10 people can do that. And the reason is because your body is fighting you. Your body has this thing that we call the set point. And in that set point, which is regulated by your hypothalamus, it comes up with a number where it wants you to be. It wants you to weigh a certain amount. Now, other things that the hypothalamus regulates are things like body temperature, right? And you can't decide today I want to be 96 degrees. I don't feel like being 98.7, so I'm just going to be colder. But there are things you could do to make yourself 96 degrees, right? You could go jump in an ice bath, and you could stay in there till your body temperature turned 96. Your body's going to fight you, though. It's going to say, I'm going to start to shiver to try to generate some heat, and eventually it's going to tell you, hey, dummy, get out of this pool because bad things are going to happen to you. And so you can think of weight loss the same way as trying to drop your body temperature. You can do it if you try really, really hard for a period of time. But eventually your body's going to win that battle, and you're going to say, I can't do this anymore. And what does it use for thermoregulation? It uses things like shivering. It uses things like, you feel lightheaded and dizzy if you get too cold. For weight, if your weight is too low below your set point, it uses things like hunger and appetite and energy level. And so people who diet excessively will start feeling hungry more and more. They'll start thinking about food more and more often. Different kinds of foods are going to become more exciting to them, things that are real high calories, so you start craving fatty foods. And your brain knows what all these things are, so it says, oh, cheeseburger, 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 right? You start thinking about those things. So just diet and exercise alone are not going to get you what you need to get to lose the weight that you're hoping to lose if you start ending up being 20 or 30 or 40 or 50 pounds overweight. And so to get that set point down, there are certain things that we can do. And one of the things we can do with the set point is we can choose the foods we eat. Because part of the problem that we have is some of the foods we eat raise that set point. And I will jump on the high fructose corn syrup bandwagon, and I'll go so far as to say is if you're looking at something and high fructose corn syrup in the store, you're going to purchase it, is the second or the third or the fourth ingredient, maybe look for a different one because that stuff is just flat out poison. It's inexpensive, it's sweet, and it's in almost everything we eat, and that's one of the reasons why we lead the world in obesity and fatty liver disease, right? Because there's so much of it, and it's so easy to get. Part of the reason that it's so easy to get is because it's cheap to produce and it's stable on a shelf, right? And so it's a great ingredient to use if you're making a food, because you can put it in a box, you can put that box on a shelf, and it can sit there for a year or two. So you don't even have to sell it real fast. So it's very stable. It's just very bad for you. So that's one of the things we want to stay away from. So if you take less of that in your diet, you're going to lower that set point a little bit. Exercise helps us lower our set point a little bit. If we're burning 1,000 or 2,000 calories a day, our believe it or not, our metabolic or our weight set point is going to come down. So I agree, you always want to start when you're trying to work on your weight and your health, making dietary choices that are better. Fresh vegetables, your wife is right, I have to break it to you, are the best option. You almost can't eat too much broccoli, right? If I came in here with a bag of broccoli or one cookie, I will tell you, you could eat that one cookie. You might even eat two. There's the same amount of calories in the bag of broccoli and the cookie, right? And nobody is going to eat that entire bag of broccoli in one meal. So if you're hungry, break out the broccoli. You can eat it as much as you want. It's still not going to be as bad for you as for one cookie. And so we want to work on our diet first. Who here cooks most of their, I won't say all, but most of their meals from scratch in the room? That's a good number. That's not very common. Most of the time when I ask that question, I get one person that raises their hand, because so many of us use fast food or pre-prepared food, this ultra-processed, dangerous food. So the thing number one is going to be working on your dietary choices. And then number two is going to be working on your exercise. And again, stealing my thunder, strength exercise, right? Walking is great, balance is great, strength exercise is important. And it's the one that most of us don't like to do. It's sort of the hardest one to get people into. Some of the ways you can do your strength training that doesn't involve going to Planet Fitness or the YMCA are the exercise therapy bands. You may have, if you've ever had an injury and you've seen a physical therapist, someone's given you one of those bands at some point in your life. But you can buy them at Walmart, you can buy them at Target. They're fairly inexpensive. They last a fairly long time. The more you use them, the weaker they get, and you do have to replace them. But they're a great thing to carry around. They don't take up much space. You can put them in a drawer in the house. And they give you that resistance that you need. So your muscles need to be constantly under resistance to maintain their size. The other, yeah?
What about yoga?
So, all right, I was going to get there, but I'll get there now. So resistance bands are great. My favorite two exercises, particularly for my patients in weight management, are yoga and Tai Chi. And yoga and Tai Chi are essentially the same thing. Tai Chi's just got a little bit more movement than yoga. And the reason those exercises are so good is they work on strength, they work on balance, which is as he said, falls are a big killer of folks as they age. So they work on balance, they work on coordination, and then they have an aerobic component, so they give you that cardiovascular fitness as well. So I think yoga is a great opportunity for exercise. I think Tai Chi is a great opportunity for exercise. Resistance bands, and if you don't want to do any of the above, you all pretty much got water bottles in your hands right now. Water bottle exercises. You can use that. It's free. You've already paid for it, so and you can use the water bottles to add a little bit of resistance to maintain that strength. The third thing we think about when we're thinking about health beyond as it comes to lowering that set point is eating behaviors. I won't make you raise your hand and get you in trouble for this one, but people who eat late at night, that tends to be a very dangerous eating behavior. And it's a sort of a self-fulfilling behavior. People will start munching on a high carbohydrate snack in the evening between their dinner meal and when they go to bed. And that'll bring their blood sugar up. And then insulin will kick in, which we don't want, and your blood sugar will come down. But what happens when your blood sugar starts coming down pretty quickly? You start feeling tired, you start feeling sluggish, and you're like, I'm not ready to go to bed. I want to watch the news, or I want to watch American Idol, or whatever program you're staying up to watch. So what do? You grab another snack. And that gives you that same thing. It makes you feel better for a little while. It revs your brain up. But then it brings in more insulin. And all of that is getting stored in your liver, which is exactly where we don't want it to be. So thing 3 that we work on with our patients are eating behaviors. And the 2 dangerous ones that I see most commonly are the late night eating, or not necessarily late night, I should say, the evening eating between dinner and bedtime. And the other are high calorie beverages. So how many people here stop into Dunkin' Donuts a couple times a week? Yeah, a few, not too many, not too many. If I could get rid of Dunkin' Donuts, I'm pretty sure I could get rid of about 50% of fatty liver disease in New Hampshire, right? Because everywhere you go, there's a Dunkin' Donuts. If you just go and you order and I'm not just picking on them, I'm using them because they're common, but you can say this about any of the other fast food beverage places. So Starbucks does the same thing, and Aroma Joe's does the same thing. But if you order a regular iced coffee from Dunkin' Donuts, which is a popular thing, that comes with 4 scoops of sugar and 4 pumps of cream. So that coffee is really a lot of fat and a lot of sugar all mixed together, it's got a lot of calories. And it's got a lot of fat in it. And so that's another one of those behaviors that people get in the habit of, oh, I have a Dunkin' Donuts on the way to work because I'm trying to wake up and get ready, and then I'm driving home from work and I'm feeling a little tired and I don't want to fall asleep when I'm driving, so I'll get an iced coffee on the way home. And you can easily consume over 1,000 calories to 1,500 calories, especially if you're the kind of person who likes the flavor pumps in those as well. Because if you're going to get your iced coffee, you might as well get mocha coffee with a little chocolate, or the cinnamon one, or the pumpkin spice one. And so all of those have even more calories, and some of them will go up to 1,200 calories per drink, which for most of us is our entire day of caloric expenditure. Yep.
What about smoothies?
Smoothies. So I have a mixed feeling about smoothies because it kind of depends on what you're putting in your smoothie. If you're taking some kale and some almond milk and a banana and some strawberries and you're mixing that all together, I think that's a pretty good choice. You can even add a little scoop of whey protein in that if you wanted to, or some chia seeds to add a little bit of protein. So I think those smoothies are okay. I think if you go to the smoothies where they make them with ice cream, if they put a lot of sugar in them to sweeten them, then you're sort of defeating the benefit. As Dr. Gilbert mentioned, what we want you to have if you're having carbohydrates is we want them to be complex carbohydrates. And so what's a complex carbohydrate? That's a carbohydrate that you find in nature that hasn't been processed, that's usually a multi-chain carbohydrate. So it's got sugar has just a few atoms of carbon in it. But when you take complex sugar, it's got many more molecules of carbon. And each of those has to be broken down before you can use it in your body. The more times it has to break things down to use it, the longer it takes for it to get into your system. And so these complex carbohydrates, they'll stay in your gut for a long time. They'll be broken down very slowly. They will not cause your blood sugar to raise very quickly, and therefore they won't cause your insulin levels to go up very quickly. And so I think if you can eat, even if you go, oh, well, banana has a lot of sugar and strawberries have a lot of sugar. True, but they're complex carbohydrates, and so they're not immediately absorbed like sucrose is. Sucrose is basically what happens when you take those natural sugars and you pre-break it down, and then you sell it that way, and it gets immediately absorbed. It immediately causes your blood sugars to go up. It immediately causes that insulin increase to go up. So if you make your smoothies with complex carbohydrates, I like them. Yep.
Can you give us some examples of complex carbohydrates?
Sure. So fruits and vegetables are good, quick examples. So most fruits and vegetables have complex carbohydrates in them. Things that I like to use as a complex carbohydrate, I like oatmeal. When you're picking an oatmeal, you want to pick one that is, typically it'll be called like an original oatmeal. So you don't want the fast cook oatmeal. So if it is designed to be made in a microwave, or if it's designed to be cooked for less than 5 minutes, somebody has already treated that and broken it down. And even though it looks the same, it's pre-broken down into those smaller molecules that are more quickly absorbed. But if you take an original oatmeal, like Quaker Oats Original, where you have to cook it for 10 or more minutes, that has not been pre-cooked, so to speak. And so if you use that, it will more slowly absorb in your body. I think a great complex carbohydrate, if you like this, if you like oatmeal, is overnight oats. Have any of you ever tried overnight oats? So you take the standard oatmeal, mix it with some kind of either milk. I personally use a protein shake when I make mine, and then a little bit of chia seeds, and then whatever fruit you happen to like. And you put it in the refrigerator overnight, and that will hydrate the oatmeal, but it will not break it down at all. So your body has to do all that work after you consume it. Part of what you're doing is you're feeding your stomach and slowing down that absorption, but you're also then sending carbohydrates that haven't been broken down into your colon, which then feeds a whole new set of organisms in your colon, which produces a whole new set of small molecules that your body absorbs. And that actually slows down hunger. It lowers blood sugar. There's this thing called the second meal effect. And if you feed yourself with complex carbohydrates, the next meal you eat, your blood sugar won't raise as high because there are compounds produced by your large intestine that actually suppress that insulin surge. And so I like chia seeds, flax seeds. A lot of it just comes down to what's palatable for you. But any of those are good choices to add into your cooking, particularly for snacks and breakfasts. Because you can kind of have those sitting on the side and they're ready to go. Has anyone ever made a chia pudding? Mm-hmm. Yeah. I think chia pudding, it's great. It's got a lot of fiber. It's got a lot of antioxidants in it. And I personally make it with, again, a protein shake. So I'll take a protein shake and chia, mix them together. And then if I want a snack, I'm going to get a lot of fiber, I'm going to get a lot of protein, and I'm not going to get a whole lot of carbohydrate out of it. Yes, sir?
So seeds a problem if you have diverticulosis? Or?
They really aren't. We'll ask the pro here because he's the expert, but yeah.
Dennis doesn't like them.
I agree. They can be a little tough on the teeth. You do have to floss if you use chia pudding. Yeah, you can need a little floss because they can get stuck in the teeth. Yeah.
They're great in the pudding, though.
They are great in the pudding, aren't they? I love them. And I think it's a much healthier pudding than making an instant Jell-O instant pudding. So, all right. So that was I got to the 3 lifestyle things that we work on when we're helping people manage their fatty liver. So their diet, their exercise, and their eating behaviors. And then number 4, and this is the one that's kind of new for most people that they haven't heard of, and that's modification of the disease of obesity, right? So we have to change the disease somehow, because when you walk into your primary care doctor's office and they say, you've got high blood pressure and you need to cut back on your sodium and get more exercise. And so you go home and you do that, but you come back, a couple of weeks later, they check your blood pressure, it's still high. They don't yell at you and say, you didn't get your blood pressure down and you didn't exercise enough and lower your sodium enough. They say, well, let's put you on a medication to help lower that blood pressure a little bit more. And so the same thing is true when you come to see us. We want to do something to help modify that disease. There are over 250 different genes that have been identified that are associated with obesity, right? So that means there's about 250 light switches on the wall that could potentially be flipped in you that will lead to obesity. Now, most of us don't have all 250 of them flipped into the wrong position. We have a couple flipped into the wrong position. And thankfully, it's fairly common which ones we see most often. And GLP-1 is one of those switches. So there's a lot of people in the US who have a GLP deficiency. They're not making enough GLP-1, and part of it has to do with the way food is absorbed through our gut and the foods that we're absorbing through our gut. So we can do things that help flip that switch. So we can give you a medication by injection that is an analog to GLP to turn that switch in the other direction. There are pills now that we can use to do that as well. There are some people have a lot of cravings because the food industry has gotten really good at figuring out how to flip this switch in your brain called dopamine and serotonin, and that's sort of like the happy feeling medications that we have. You've probably heard, if you're on antidepressants, of them being SSRIs, selective serotonin inhibitors, right? So there's ways that we can modify serotonin in our brains with food to make us more interested in that food. And the people who are really, really good or bad at this are the people that make cereal, right? They've figured it out. They know exactly how much sugar to put into that cereal, exactly how much flour to put into that cereal, exactly how much fat to put in there, exactly how much flavoring to flip that switch. And you go, you know what, I could have another bowl of this. And you get really, it's really, and you think, it's only cereal. How bad could it be? Yeah, it's very bad. So stay away from cereal. But so we have medications that can block some of those pathways. The pleasure pathways, that like things that are targeting that, like brownies target that, chips, Doritos, goldfish, the little Pepperidge Farm goldfish. They all target that pleasure pathway. We can block that with something called naltrexone. So there's different medicines that we have that can block different pathways. And depending on which switch is on in your particular case, we can flip that switch off with a medication. So there are quite a few medications that we use that help people modify the disease of obesity. There are even more coming out because once people started recognizing that obesity was a disease and started doing a little research into it, they said, well, there's actually things we can do to treat obesity. Amazing. Nobody knew this for 50 years, and all of a sudden now there's a ton of research going into this. It was only 13 years ago that the AMA defined obesity as a disease. So for most of the people in this room's lifetime, it has just been considered kind of a flaw of character. But it truly is a disease, and I can prove it to you because I can flip it on and flip it off with a medication in pretty much anybody. The other thing that we can do for people who have obesity is we can offer them surgery. And you've probably all heard about weight loss surgery in the past. And there are some people who love weight loss surgery. There are some people who hate weight loss surgery. But I'll tell you, we thought when we invented these surgeries 40 or 50 years ago, that what we were doing was we were just making it hard for people to eat. So we were changing the way that the intestine was connected. We were bypassing certain parts of the intestine. We were basically trying to make it harder for people to eat. And people lost weight with these operations. And we thought, see, that's what it is. It's if you make it harder to eat, then they'll lose weight. Well, it turns out the more we studied it, the more we realized people after those operations can still eat a lot if they want to. There's ways to kind of get around the modifications, but what they can't change necessarily are the hormonal changes that occur. And a lot of the hormonal changes that occur when you have a weight loss surgery mimic the medications that we use now. So it affects things like your ghrelin level and your leptin level and your GLP-1 level and your GIP level, and so your insulin levels. So a lot of the medications that are coming down the line now that you'll see in the next 5 or 10 years to help treat obesity came because they looked at what changes occur to patients who have had surgery and then said, well, what if we just give, instead of doing a surgery to give that hormone change, what if we gave someone a pill to make that hormone change? And that's where a lot of these drugs are coming from now. So they're looking at the changes that occur from surgery and then trying to mimic that through pharmacology. And it's been pretty successful so far. Part of the interesting thing about surgery for me is I think of surgery, if you think of each pill as a bullet fired from a gun, surgery is like firing a shotgun because it changes a lot of different hormone levels in a lot of different ways. And in a lot of ways we don't understand yet. So sometimes people will do really well with a single medication. And there are patients who people you've probably heard of who take one of those GLP-1 medications and they lose 100 pounds. But there are patients who will take one of those GLP-1 medications and lose no weight at all. And I see patients like that every day. And that's because in that 100 or 250 light switches on the wall, the GLP switch isn't the problem in that particular patient. So giving them more of it's not going to make anything better. But sometimes surgery will, because surgery is just like walking up and just going like that to the light switches. You just hit a whole bunch of it and a bunch of them change. We haven't figured out what they all are yet, but we know that it does more than just the individual medicines. And then there are patients who have had the surgery, so we did that with the light switches, and a lot of them are in the right position, but they're still either not losing enough weight or regaining weight. And those are patients who we can then go in and target with individual medications to flip those last few switches. And oftentimes that's very successful. The goal for all of this is that 5 to 10% total body weight loss. Because it's been shown very clearly that the 5 to 10% body weight loss will decrease your triglyceride levels, it'll increase your HDL levels, it will decrease your blood glucose levels, it'll decrease your blood pressure, and it will lead to longer longevity, so a longer life. And so if you take the medications, you can flip some of those switches, you can lower that set point, but they're only really effective if you take them in a supervised way, if you also incorporate the food changes and the dietary changes that we talked about, if you incorporate exercise, which I think is the thing most people don't do, but critically important, and if you take them safely under supervision, because we don't want to end up with things like sarcopenia, where you're losing all of your muscle. Muscle mass really needs to be preserved at all times, and the only way to do it is to work on it. So there's no pill to keep your muscle mass. The only thing that keeps your muscle mass is moving things around. And that's why that's such a critically important part of the process, is staying physically active. Yes, sir.
So your 5 to 10%, that's regardless of what your current weight is?
Correct.
And
Yeah,
that's continuous?
it's really weird. So this guy named Blackburn, who was a researcher at Mass General, actually, just down the road, studied thousands, tens of thousands of people, and found that consistently, if people lost 10% of their weight, they lived longer and had fewer cancers. And that probably has something to do with the inflammatory state of your body. And so we all talk about inflammation, and if you bang your knee and it swells up, that's inflammation, right? But we all have a baseline level of inflammation at any given time. And some people live in a pro-inflammatory state where they make more of the inflammatory mediators. Some people live in an anti-inflammatory state. And losing weight puts you in an anti-inflammatory state. And so all of the inflammation does some very good things for us, but it can also do very bad things for us, like turn over cells and cause cancers. So that 10% weight loss tends to put people into an anti-inflammatory state. And that tends to be why it cuts back your cancer rate and lets you live longer. Things like blood clotting get affected as well. So yeah, and it's pretty interesting, because if you're 220 pounds, that means you got to lose 22 pounds to do better. If you're 400 pounds, you got to lose 40 pounds to do better. And you think, like, relatively, that's not a big number if you're 400 pounds, only losing 40 pounds, but it actually plays a big role. Now, will losing 140 pounds be better for you? It will be, right? And so, but that 10% is a very reproducible change in terms of improvement in your health. And we've talked a ton tonight because we were mostly focusing on liver health, about metabolic health. Another thing that weight plays a role in that we haven't talked about yet is just your skeletal health, right? And so it's hard to move 400 pounds around. It's hard to climb up a flight of stairs. We all have water softeners, right? Or if not, fireplaces where you had to carry a big load of logs up the stairs, or your bags of salt pellets. It's hard to go up the stairs. Now imagine if someone's 150 pounds overweight. Think about how much wood you're carrying to carry 150 pounds up the stairs. That's a big bundle of wood. And that's every day, all day for those patients. So it really can be very damaging to the hips, the knees. I don't know about you, but like when I bring the bags of pellets downstairs for my water softener, by the time I get to the bottom of the stairs, carrying 2 of them, which is 80 pounds, my knees hurt. My knees don't normally hurt when I climb stairs, but they do for extra 80 pounds. And so losing that 10% will help you metabolically. It may not help you from a skeletal perspective, and we call that fat mass forces in my world. So the more weight you can lose, the more fat mass forces you can lose, and that'll help things like arthritis, spine problems, stamina, because you'll be able to walk farther and do more exercise. Yeah.
Is there any truth to what they're calling it, gut leakage, and how that works into the metabolic picture?
Yeah, I think so. And he's the gut expert, but I'll give you I'll give you the surgical understanding of that, and then we'll let a gastroenterologist speak to it as well. But our gut has trillions of bacteria in it, and those bacteria are doing things. They're not just sitting there. They're eating, and they're growing, and they're multiplying, and they're releasing mediators that are breakdown products of what they eat. So like the oatmeal I was just talking about gets into the gut, then those bacteria break some of that down. They release little fatty acids. Those little fatty acids then get absorbed by your body. And if your gut is healthy, the system that kind of keeps everything in check works really well, but your gut is actually designed to use some of the energy created by those bacteria. And if you don't have those bacteria or you're not feeding them properly, the gut gets leaky, and then different kind of molecules that we don't want getting into us can get into us.
Yeah, I agree 100%. I'll say yes, but. So there was a really cool experiment where they took skinny mice and fat mice, and they essentially did like a stool transplant, so a microbiome transplant from the skinny mice to the fat mice, and the fat mice lost weight. And they did it backwards, and the skinny mice gained weight. So I'll say there's absolutely what Dr. Catania said is spot on, that there's things related to our microbiome. The but is, I think there's some people that think that they understand it more than we do. And so there's some people who will say like, oh, you need to shift your insert something that they're about to sell you by, and we're not there yet. We're in the infancy of understanding it, but it's like understanding the universe. We're just barely beginning to. And I think there's more to come on that. But like someone who's telling you that if you just take this, it'll make it all better.
I had a feeling it was kind of a combination of gut also affecting the liver.
Yep.
Yeah, because all the blood from the gut, the first place it goes is the liver. So the liver gets everything from the gut first, and that kind of speaks to the inflammation that we had talked about, and the liver inflammation. If there's a lot of inflammatory things coming from the gut, the first place they hit is the liver, and then that makes the liver inflamed.
How do you, knowing that it's in its infancy, what do you do?
Exactly what he said. A tremendously healthy diet will make your microbiome shift.
Yeah, one of the questions I get asked all the time, because as Americans we love pills, and anything you can get in a pill, you'll get. Unfortunately, most of pills that aren't coming from your pharmacy are not regulated at all, right? So when people say, oh, you need to add 1 million Saccharomyces cerevisiae to your gut, how do you know? There's a trillion things in it. Any one little pill is going to do such a small amount to you. And there's 10,000, 20,000 different bacteria in there. So how do I know you need 10 of one and 4 of another? I could never test that to prove it. So they just throw things in there that sound good, and then they market it. And the budgets on those companies are 90% marketing and 5% production, because it doesn't matter what they give you as long as they make you buy it. But if you eat well, if you put healthy foods into your gut, I mean, we were all designed to live, right? And we're pretty well-designed creatures. So my answer to that always is feed the gut what we're supposed to be eating. Some roughage, some vegetables, some complex carbohydrates, and the right bacteria are going to grow, and they're going to do what they need to do. Now, is that always true? No, there's times when you need to be on antibiotics, and there are diseases of the gut like SIBO that you've probably heard of, or diverticulitis. So we're not perfect organisms, but I think in general, if you feed us well, we do well.
So are you anti-probiotics and prebiotics?
Not anti. There's absolutely some things that they're very helpful with, particularly if you do go on antibiotics. They can help you repopulate a little bit quicker, so you can offset some of the post-antibiotic diarrheas, C. diff, things like that. Yogurt's great. I eat yogurt every single day. I think the challenge is exactly what Dr. Catania said is so they're regulated as food, not drugs. So they really just have to not be deadly, and it's funny because food actually is, turned into a poison, but that's another conversation. But it's really hard to say what you're getting. Is it the same as what you got from the last time? The one thing I will say is that a real probiotic should be cold and dark, right? So it has to be light protected and cold, and if it's not, you're probably eating something that does nothing.
Yeah. Go ahead. Yeah.
How about kombucha?
So kombucha, yeah. So fermented foods, right? So fermented foods come essentially preloaded with bacteria. And so kombucha, kimchi, kefir,
Sauerkraut.
yogurt, they're all preloaded with bacteria that humans have been using for millennia, right? So anything that's been stuck around for 2,000 years probably is a good thing, right? Or we would have gotten rid of it at some point. So yeah, I think that's a good.
Sauerkraut, right?
Mm-hmm.
Right, sauerkraut. Yeah, those are those foods that are historically humans have gravitated to. Probably we did it for a reason.
Me.
And you don't have to like it, so you can pick something else. So. Yeah.
What do you think about almond milk or Truvia or Stevia?
Oh, 3 different ones. Okay, yeah. So, almond milk. I like almond milk. I drink almond milk. I think there are some benefits to the nut milks that they have, like when there's oat milk, there's almond milk, there's soy milk, especially for people who are lactose intolerant. And there are some downsides to cow milk because a lot of cows come from places where they put a lot of hormones and a lot of antibiotics into their feed to keep them alive. So you sort of dance around one problem in favor of another problem. And so, because the nut milks are sort of artificial, right? And we were talking about how important it is to eat these natural foods. So I do use some almond milk. I can tolerate, so I do use some cow milk as well. And so I kind of use a little of both. I hedge my bets because I'm not 100% sure what the right answer is. In terms of the artificial sweeteners, all of them have pluses and minuses. Stevia is a natural compound, so I like that one a little bit more. I like honey. If you like honey as a sweetener, I think it's a pretty good, pretty safe sweetener. A little less fan of the purely chemical ones because those things are designed basically to turn on a particular receptor in your tongue, and so it's just 100% chemical. So those I try to stay away from. Yeah.
Real maple syrup.
Yes.
Go for it. If I said no, everybody would come up here and beat me. So, but yeah, no. When I was talking about those overnight oats. So I put a little bit of honey in my overnight oats and a little bit of maple syrup in, because just plain old oats can be a little blah. But yeah, so I think I do use those myself, and the small amounts are good.
So this is back to the fatty liver disease. If they pick it up on this CAT scan, can they determine the extent of the fatty liver on the scan? And why don't they say that on the report? They just say it's there.
Yeah, so the 2 things you can get from a CAT scan, some of that, they'll see that there is fatty liver, and then if you've developed cirrhotic changes, they can pick that up so they can see some of the,
So does it have to be cirrhotic before they determine it?
So a CAT scan in and of itself will not pick up early fibrosis. It has to get the nodular contour. You have to start getting some of the portal hypertension, so varices, ascites, things like that, or splenomegaly. And that's one of the things that's nice about the elastographies, either the FibroScan or the MRI, is that you actually get a little bit of information about how fat the liver is. So like you get a score, you get an S score and an F score.
So on that FibroScan, I couldn't tell, is that just purely external vibration, or it's not any, it looked like there might be a needle pick.
No, that was just a picture.
That
Yeah.
was just a picture.
Yeah, no, it's strictly just taking different
Isn't it
measures.
important in knowing what level you're at, and if your labs are all normal, and you're not a diabetic, and your blood sugars are all right, I mean.
It's helpful to know. So that S score, so how much steatosis there is
Okay.
helpful. It lets us know how much work we have to do. And again, if you're showing any evidence of fibrosis, then we really want to get ahead of it before you progress.
Okay, 'cause it's.
Yeah, well, but I will say one of the
Staging
things.
has never been discussed.
Yeah, one of the things that we see a lot now, and this is basically on a federal law, is all the imaging getting released to patients. And just believe that radiologists have to say the worst possible thing every single time, because if they don't and they miss something, then they get sued and they lose $1 million. So every little thing that they see, they're going to say, oh my God, and there's fatty liver, and oh my God, the adrenal's a little bit thickened, and oh my God. And I won't say most of it because I don't really know what the number is, but a lot of times you have to take it in context. And so you don't lose too much sleep if you saw one CAT scan that said some fatty liver changes noted, because most of the time that's not too significant if all those other things like you said are normal. Your LFTs are normal, and your blood pressure, and your blood glucose.
Should those, your lab screen you annually?
Your primary care doc is probably doing that, I would think.
Should be.
Or should it be suggested based on that?
Yeah, and I think oftentimes they will, but this is a totally different topic, but one of the traps I think we get ourselves into now is the over-testing based on minor abnormalities. I just had a person in the office today who, this will be a classic one, you'll see. So a woman who came into her primary care doc's office, she was having pain here that was radiating to her back, and they said, well, that sounds like gallbladder, let's get an ultrasound. So they got an ultrasound, and the ultrasound showed gallstones, so not surprisingly, but it also showed a slightly enlarged common bile duct, which is one of the ducts from the liver. So that prompted an MRI. The MRI then said, no, the common bile duct looks really okay, but there's a nodule on the adrenal gland. So that prompted another MRI. So this patient had about 2 months worth of testing, which probably cost $500,000, no, not $500,000, but $50,000, and she just needed her gallbladder out. So you just have to, yeah, you have to be able.
It wasn't
I'm the one that
they
missed that on several ER visits.
The surgeon had so much fear that I ended up being all those tests for over a year, only to finally get to a great gastroenterologist, and he said, and I brought everything to him, he said, I think it just all looks normal for your age.
Yeah, right, so
But
you should pay attention to everything you see, but at the same time, don't lose too much sleep over it because.
well, I wasn't doing that. The surgeon was being cautious, but that's all right.
So are there any symptoms until you got cirrhosis?
Usually not. I mean, if the liver swells, you can get some vague discomfort in the right upper quadrant, but oftentimes people have fatty liver with no symptoms whatsoever.
What do you think about, I mean, I think I know the answer already, but all the new liver cleansing stuff?
Oh, yeah.
Yes,
I don't own stock in any of those companies.
Yeah.
So, are you familiar with Fatty 15? That's a new,
I don't know fatty 15, but
it's a new drug
yeah. So
for fatty liver.
if you can buy it over the counter, it's not a drug, it's a food, right? And that's just by definition. So the FDA doesn't regulate any of that. You do not have to submit any tests on. In fact, we could all just pick our favorite recipe if we wanted to, make it, sell it, and say that it causes you to live an extra 7 years. And then at the very bottom, it's going to say not evaluated by the FDA. Mm-hmm. So you can say anything. I'd say to stay away from all of them. They're basically just trying to take your money. That's my opinion.
Except if your best friend's taking it, she feels great. That's something.
There's one called the placebo.
Yeah.
As a type 2 diabetic,
Mhm.
is it safe to do intermittent fasting?
Good question. Do you know what your A1C is?
It's 6.3.
6.3? Okay, that's good. The answer comes down to which medications you're using to control your diabetes. There are some medications like metformin that you can fast on. GLP-1s you can fast on. There are some medications that will cause your blood sugar to lower if you don't eat regularly. And so if you're on one of those classes of medications, then it's not. So that's a good question for your primary care doc to have them look at what medications you're taking. And if you're on one that's known to lower a normal blood sugar, then you can't really fast on it because your blood sugar will just keep dropping.
Especially like insulin.
Yeah, well, insulin is the prototypical one. You can kill yourself with that.
Why does metformin say take with food then? Because
Could-
I always make sure I eat something
From
when I take my
GI side
metformin.
effects.
Yeah, GI side effects.
Yeah.
So
Yeah.
like gastrointestinal,
Yeah.
Nausea and diarrhea.
okay.
These are great questions. Yeah.
So Facebook algorithm's got a couple questions. So I always see like, they talk about the fatty liver diet and how you should eat eggs, like there's always eggs like in every day. For somebody who can't have eggs, what is the recommendation to, besides like fruit and vegetables?
Lean protein.
Any kind of protein?
Lean protein.
Yeah. So why, and is it an allergy or just an intolerance?
Allergy.
Yeah. You know what we don't eat enough of in the U.S. that is great for your colon health and great for your blood sugar? Beans. So, and in many countries in the world, beans are part of their breakfast. I don't know why it's not here, but it's not. Yeah, well, there you go, Boston baked beans. But I mean, like if you go to England or Ireland, beans are on every breakfast. And so that's those are a good alternative for eggs.
But see, to me, those things cause me diarrhea. Fiber.
Well, and
Fiber
everybody's
stuff.
different, so you can't
what
say
do
it's
you
all
do
true for everyone.
If you can't have that much fiber.
Do you eat
just-
yogurt,
it just-
yogurt or other
Yeah.
proteins?
Yeah, other proteins, is it just the fruits and vegetables, like Brussels sprouts is what caused my gallbladder to erupt.
So,
And I ate a lot of them because I used to go to the senior center and everybody used to put theirs on my
yeah,
plate.
I love Brussels sprouts. So we do have at our weight loss program, we do have 2 registered dietitians who are really good at helping people do substitutions. So like for you and eggs, they could say, they would sit down with you and say, here are the 10 different things you could try instead of eggs, or so they're good at doing that, and they're actually way better at it than I am.
Me too.
All right, it looks like people are getting ready to bolt.
One more question for this, for you, another Facebook thing. So you see like supplements out there that say like, milk thistle is not gonna do the job, you need, I think it's a selenium or something. What is up with that?
A lot of them do have some benefit, but I would say it'd be very important to actually sit down with a nutritionist and work through them. So for instance, berberine really helps with modulating blood sugar, and therefore it helps with the insulin resistance. But you have to take them a certain way, and I would say that there are some that are helpful, but you want to do it in a very kind of controlled and have a team back you up with that.
All right, do you have a wrap up you want to say? Or?
Thank you for coming tonight.
Yeah.